just getting started, and so good afternoon, and just want to say thank you to Donna and the organisers who has invited me. I'm speaking about the tricuspid dilemma. I've changed the name a little bit, to do or not to do. Big question, you know, always in theatre, should we do the tricuspid or not? The dilemma is this, and that is that a good echo service, this is Henry Skinner, the guys from Nottingham produced this and published this a few years ago, so that it says that we will find 6 to 10% new progressed pathology in the operating room. A surprise, surprise. In 66% of the time, this will change this surgical strategy from what we start off with. Kihara, they've actually found, and they published this in Cardiology 2009, that from the start of the operation to the end of the operation, 11.4% intraoperative new findings that you will find, stuff like wall motion abnormalities, prosthetic leaks and things like that. So, and half of those you will change the surgical strategy. In a tertiary referral center, 20% of this will involve this forgotten tricuspid valve. So, you know, why do we actually find that we have, why is this the forgotten valve? You know, why is it the forgotten valve? Is it important? If it's tricuspid valve is not important, why don't we can just ignore it? Then we just have a quick look at what does the guidelines recommend, and then we'll see what the evidence say. You know, the evidence and the guideline are two different entities. Firstly, why is this the forgotten valve? Why does it get into the theatre undiagnosed? And that is, it's got a protracted latent asymptomatic period. 60% of it is symptomatic. Less than 20% of these patients will have, you know, something that you can pick up in an investigation. 75%, and the new AHA guidelines actually says 80% of it's functional. So it's secondary to left-sided disease. So there's left-sided murmurs on the left-hand side, there's left-sided pathology, and you don't see it. It's a big surprise when you get into the theatre. Then the other thing is the surgical reputation, that it is extremely bad. In the early days of cardiac surgery, really up to a third to half of the patient actually died perioperatively. That's now slightly better. But still, ignoring it is at a great peril, because reoperation has got a very high in-hospital mortality. The STS says it's only 8.8%, but if you read the fine print, in reality, they say in the same almost sentence that the 5-year survival of this reoperation is only 41%. So, you know, this forgotten valve is actually quite important. Just a quick look at what happens, and the only figure that's really important is we operate on 0.5% of sick valves, sick tricuspid valves, compared to 10% of aortic valves and more than 2% of diseased tricuspid valves. Now, is the valve important? You know, why don't we operate on it? Is there any evidence that this valve is important? I think we all know this about study from NATH, which they looked at over 5,000 patients, and we can see that the survival is quite severely compromised in moderate and in severe tricuspid regurg. But if you look at the even mild tricuspid regurg, just because in the study it wasn't found statistical significant, in fact, if you look at it in a different way, you find that the real mortality was actually 1.4% per year, which I think is significant. So yes, that is the first proof that we have that it's important. The second is this Messiker-Zieten study from the Mayo Clinic, which just looked at quite severe tricuspid regurg with a flail segment, and just looked at again survival and a long-term survival, and then also at the event rate that we have. And you can see that it's a very, very high event rate, and that yes, the 10-year, the long-term survival is definitely compromised. This is just a summary of the same study, and which just shows us a 10-year mortality is 36% at a yearly mortality of 3.8%. So although this disease is not an absolutely acute disease, it does influence long-term outcomes and progressively influence the quality of life of patients, actually quite at an early stage. Next thing is to have a look at, before we start looking at what our loose and fast evidence says, to look at what the guidelines say. As you all know, the AHA guidelines have just appeared at the end of last year, and then we've got our own guidelines in Europe, which is the 2012. From an echo point of view, we've got these two sets of guidelines that all involve the tricuspid valve. You look at these guidelines again, at the executive version of this, you find page 2461 to 2063 is devoted to the tricuspid valve, and two of those pages are actually mitral valve tables. Tricuspid valve is again the forgotten valve in these guidelines. So there's not much. What actually complicates the guidelines even further is the fact that you have to go to the mitral valve guidelines, which says that in a mitral valve center that's got a chance of having more than 90% success rate in mitral valve repair, there's evidence that you can do tricuspid annuloplasties successfully. So you have to not only look at the current guidelines, but you have to look at the mitral valve guidelines as well to form a complete picture. I'm not going to go into the guidelines much further, to rather just point out that in the European Society's guidelines, we find that everything is backed only by level C evidence. In the new AHA guidelines, there's actually in mitral valve surgery, there is level B evidence that shows that, and that's why they've reduced the degree of regurgitation required to do the tricuspid valve in mitral valve disease. So there's now level B evidence to do, and which also give you a class 1 recommendation. So the guidelines has been quite pliable over the last few years. Echocardiography is the ideal technique to evaluate tricuspid regurg. This is from the European guidelines. So we're in an ideal situation to make a decision on this. So what does the evidence say? Let's forget of the guidelines and use that in conjunction with the evidence. Which parameters are important? Firstly, obviously, the degree of valvular disease. We're not going to spend too much time on that because it speaks for itself, and we can use the guidelines to tell us what's going on. And then the tricuspid annulus diameter is of paramount importance for making a decision. I think to me, it's more important to make a decision on the tricuspid annulus diameter and the things that causes it, the right ventricular function, atrial fibrillation, and pulmonary artery pressure that causes this tricuspid annulus diameter and it causes the annulus to dilate. So let's go just the degree of tricuspid valvular disease. Obviously, as indicated by all the guidelines, which is only basically for severe tricuspid regurg in left-sided surgery, and then if it's only in some symptomatic severe standalone tricuspid regurg. But anything this is going to be slightly controversial, but there's proof and evidence in quite a lot of studies. Primary tricuspid regurg, moderate and worse, needs repair. And you can see that NATH has showed that, and Tiruna shows it quite clearly. Anything more than mild, find at mitral valve surgery, and there's a plethora of studies that actually support this. Mild and more if the tricuspid annulus is dilated, and we've got also quite strong evidence to support this. The next thing is what we've spoken about, tricuspid annulus diameter. I think there's a direct correlation between the tricuspid annulus dilatation and tricuspid regurg progression. The tricuspid valve's only got one way to go, and that's out. And this is all as an after effect of either left-sided disease or right-sided disease on itself. But it's mostly, as we said before, that 80% of this is functional. So it's as an effect of anything else. And I'll show a little bit later that we have to treat this. But the main thing that we can make a decision is on this tricuspid and on this TA dilatation. It's very reliable. And you can see this study that proved that and showed this direct correlation between this diameter and progressive TR. Goodness me, something, okay. Now, tricuspid annulus diameter measurement is a little bit contentious in a little way. There's a lot of things in the literature, and there's a lot of numbers around. The first thing is this, just to say to yourself when you start off that the normal tricuspid annulus diameter is only 28 millimeters. That's more or less what it is, and that's in the diastolic 4-chamber view. You see, the Colombo, they've worked, and this is worked into all the guidelines. It's this 21 millimeter per square meter body surface area. You can measure that, and you're going to forever find that your patient is dilated, from a body surface area. And if you say, and you wait until it's 21 millimeters per square meter, you do a tricuspid annulus annuloplasty on every patient. So it's go to but this is only taken to a maximum of 35 millimeters, and that sort of clarified that a little bit. Dreyfus put 3 fingers in the heart, and he measured this as 70 millimeters and equated this to 40 millimeters on echo. I have to, for the American rule, if you'd ever say anything in the USA about this, then you have to measure the Maslow study, because otherwise you just get crucified if you don't. They compared 4 views, the transgastric view, short axis view had been found. He found the transgastric short axis view correlated the best to the surgical measurement. The European Society guidelines is 32 millimeters systolic diameter or 34 millimeter diastolic diameter, as anything higher than that is dilated. And Steve Bolling felt that if the TA diameter is more than 2/3 of the mitral diameter on the 4-chamber view, it's dilated. There's a very big feeling that if the annulus is dilated, and a lot of the literature at the moment support it, then you can repair regardless of the TR grade. If the annulus is dilated, it's better to go ahead. Just want to say something about the Maslow study, just comparing the 4 different views, because there's also always a lot of questions about this. And he found the best correlation between this transgastric view and the surgical measurement. My question about the surgical measurement is, only 18, there's a 20-patient study, only 18 of the patients' data were used. The measurement was done with a Londe-Bakey forceps. It does not sound, I'm not critical, but it doesn't sound very scientific to me. So, I take this with a little bit of a pinch of salt, this study as such. So we're going to move on the next important thing that for us is to have a look at, and that's pulmonary artery pressure. The effect of the pulmonary artery pressure, both on progressive TR as well as on the tricuspid annulus. You can see that the pulmonary artery pressure negatively impacts on the midterm recurrent TR. If you produce your pulmonary artery pressure just a small bit, from 48 millimeters to 34 millimeters, so the residual TR is reduced from 42 to 3%. So a small, tiny little difference that you make in the pulmonary artery systolic pressure is going to make a big difference in your post-operative TR and in your decision-making here. So the pulmonary artery hypertension is also associated with a significant TR grade at the follow-up. You know, and you don't get your proper remodeling. What happens is that the right ventricle just keep on dilating and develop late TR. So again, yeah, the bottom line is you've got to repair your valve and you do an annuloplasty as indicated, and if it's indicated, but you have to do something about the pulmonary artery systolic pressure. You have to treat this, otherwise. And also treat the cause of it, if there's a treatable cause. Otherwise, you're not going to have any luck with this patient. Right ventricular function, which we've just spoken about. I just want to you know, my quick fixes and the quick fixes for right ventricular function, because this is important again with the tricuspid annulus dilatation. The TAPSI. If the TAPS is less than 15 millimeters, if the right ventricular systolic area is less than 20 square centimeter, if the tricuspid annulus systolic velocity is less than 11 centimeters, they all identify a right ventricular dysfunction. If that right ventricle is dilated, then you're not going to have any luck with this patient afterwards. They are heavily strong predictors of progressive TR post-procedural. So the bottom line is you've got to repair this or replace the valve as is indicated, but you've also got to treat this right ventricle. There's or the cause of the right ventricular failure. There's a couple of exceptions here. If the TAPS is zero, if that right ventricle is not moving, and you've got pulmonary artery flow reversal, you do not touch the heart. They've got basically 100% post-operative mortality. It's a very good indication to actually do a closed chest TOE preoperatively and get the patient out of theatre. Again, right ventricular ejection fraction of less than 20% predicts post-operative death. We've got a very good study showing that. And if you don't, you know, look at these, if you've got a TAPSI of less than 8.5 millimeters, so it indicates a right ventricular ejection fraction of less than 25%. I know these are rough figures, but we work in a bit of a rough environment, perioperative. Another factor that's coming into to tricuspid valve and tricuspid valve repair is atrial fibrillation. If you've got preoperative atrial fibrillation, it's an independent contributor to late tricuspid regurg. So if you don't do anything about the atrial fibrillation, your patient is in trouble. The main thing is here, if you do a valvuloplasty in any form, you have to treat the atrial fibrillation with a maze procedure or modified maze procedure or the RFA maze procedure. But you've got to do something about the atrial fibrillation, otherwise you're not helping your patient. Another big factor is pacemaker leads or ICD leads. You can see just normally on a normal basis you get 1 grade more if you from a pacemaker in TR, and ICDs are generally worse. Even if you're going to do surgery, you have to look at that. You're going to need, if you don't do anything about the pacemaker, you redo within 6 years. You can see here, if you do the repair and if they've got pacemakers, you see that they all have severe TR within, almost half of them have severe TR within the next 5 years. So you've got to do something about these pacemaker wires. Don't leave them where they are. Reposition them. You can put them outside of the ring. If your surgeon is you're happy with that, you can put them outside the ring, or they can use and switch to epicardial pacemaker wires. Another important factor is tricuspid valve tethering. This is important because, I mean, if has got a direct impact on the outcomes of patients. If you've got this pre-op tethering height of, I mean, this has all got to do with right ventricular dilatation. If that's more than 1 centimeter, 55% had immediate repair failure. So the repair failed immediately. If you've got a tethering distance of more than 7.6 millimeter or an area of more than 16.3 square millimeters, you can't do an annuloplasty on its own. It will fail. it will fail immediately in 100% of cases, and you have to do an adjunctive procedure. So if you have the valve tethered like this, you have to replace it or have your surgeon do a complex repair. Mitral valve, tricuspid valve in mitral repair, again, we spoke about this, there's a plethora, absolute mass amount of evidence that show that if you've replaced the mitral valve, or repair the mitral valve, you've got to do something about the tricuspid valve. If there's any annulus dilation or any form of regurg, because you are fixing the septal cusp, and you're going to have a medial directed jet. I would skip about the chamber side and dilated cardiomyopathy speaks for itself. If this all will just support and help to support a really bad heart. And you can see that the bonuses study actually shows that how the right ventricular dilatations and preoperative right ventricular dysfunctions are great predictors of late significant TR development. A couple of comments. Adding a tricuspid repair, if indicated during left-sided surgery, will not increase your perioperative risk. Not going to say anything about which operation, that's not my job. Just going to summarize. The real question should be, is there a reason not to do the tricuspid valve rather than a reason to do it? Thank you.